Thank you as well for providing the opportunity to speak with you. I'm going to be talking about something very different from the conversation we've been having today already. I'm going to be talking about malnutrition and its treatment for older adults, specifically in the community sector. Oh, just, do I move it with the clicker? Okay, there we are. Great, my disclosures just for you. And then continuing on. So I want to actually as well acknowledge the Canadian Malnutrition Task Force. You probably have never heard of this group before, but we've been in existence for about a decade, a little bit more than a decade now. And we're a group of clinicians, decision makers, and investigators forming a standing committee of the Canadian Nutrition Society. And we have been working in this space of trying to advance nutrition care in Canada with research, education, and interdisciplinary collaboration. I'm one of the researchers that's behind much of the work that we've been doing. Oops, back it up. So as you know, the world is aging. And so we're actually just ending the World Health Organization Action Nutrition Decade. It's coming up the end of it. And if you know anything about the Action Nutrition Decade, it's about the idea of the dual burden of malnutrition and how we need to, with our food supply and thinking about sustainability and healthcare, how to address this double burden of malnutrition. We're also just starting the WHO Decade of Aging Healthfully. And the world is aging, as we all know. And so this is a pertinent topic to be thinking about, is how we address this issue. One of the key issues that the World Health Organization has identified that we try to mitigate, hopefully in the next decade, or work towards mitigating, is this idea of frailty. And so in the WHO, it's actually talked about as lack of function and lack of ability to do the things we want to do, whether it be cognitive or physical. But in much of the world, we talk about it as frailty. And this is a medical condition that is basically reduced function and capacity in older individuals. And inactivity as well as poor nutrition are big components of this. And the poor nutrition piece comes in through lack of appetite, lack of food intake, as well as weight loss and muscle loss, and of course, micronutrient malnutrition that we've already talked about today as well. What is malnutrition? We like to use this definition with a CMTF because it's more robust than just thinking about protein energy malnutrition in its that form. It's actually looking at micronutrients as well. And the idea that malnutrition occurs when we see this imbalance, whether it be energy, macronutrients, or micronutrients, ongoing for a period of time, it changes the function in the body and the tissue in the body, and responds to refeeding, unlike other things like cachexia, for example. So how do I want to conceptualize for you today what I'm going to talk about with respect to this malnutrition? So much of the developed world has been thinking about malnutrition, especially in the acute care space, for several decades now. But we haven't been thinking about malnutrition in the community space and the idea of specifically older adults being potentially malnourished. And the issue is we're often not looking at upstream enough the determinants of poor nutrition in a way that we should be with respect to nutrition risk and malnutrition. And so I'm going to be speaking on that end, the left-hand side of this diagram today. So we know this is some work that we've done, infographics with the Canadian Malnutrition Task Force over the last few years, and just give you a sense of why this is important. So in Canada, 1 in 3 seniors is identified with nutrition risk in the community. Nutrition risk being that upstream version of which can lead to malnutrition over time if we don't stop it. We know that 1 in 4 patients in Canada will be malnourished on admission. Many of those are older adults. When they're discharged to the community, 1 in 10 will only see a dietitian, even though they're malnourished when they leave the hospital. And they will have a 2 times higher rate of re-entry into the hospital because of that malnutrition. On the right-hand side, you see the impact of poor quality diet in older adults, risk of falls, loss of balance, loss of independence. So there's things that the World Health Organization has identified as targets to promote healthy aging. And so nutrition has a huge part in that goal. This is actually the word version of a beautiful diagram created by Volcker and colleagues in Europe around the determinants of malnutrition. And it unfortunately didn't have copyright protection that I could use in this wonderful presentation today. So I've tried to put it in words for you here. But at the top, and it's a beautiful triangle. In the middle of the triangle, they actually have why malnutrition happens in older adults. So this idea of low food intake is one of the reasons, but also nutrients not being available to the body, which again, we talked about bioavailability already today. or increased nutrient requirement. Those are the three key mechanisms why someone might be malnourished. And there's often a combination of these things happening. They then have around that center of this triangle the direct determinants, the things that directly will lead to one of these etiologies of malnutrition. And you can see many of them are determinants, things like forgetting to eat, unable to eat, restrictive diet, things specific to the older adult population that may be linked to cognition as well as other comorbidities. Then there's these indirect determinants that are around that even further, things like sensory changes, poverty, etc., that can lead to malnutrition. And finally, outside of the triangles are other factors like older age, hospitalization, etc. This diagram is based on consensus. It's not actually based on evidence. And actually, they've challenged the research community to think about how can we actually confirm that this model does actually exist, because there hasn't been large databases, unfortunately, to test out all of these determinants. What we do know is from a variety of research that there's a variety of these risk factors or determinants that, again, are on the left-hand side of that early model that I showed you that are associated with poor food intake and leading to malnutrition. Things like depression, disability, challenges with oral health, etc. So we know these things cause malnutrition. On the flip side, we also have treatment. We know how to fix malnutrition. The problem is we don't figure out who needs to be treated, unfortunately, in the community setting. Acute care, it's easier, I guess. We've been doing some work in that area for the last decade or so. People come into hospital and you can screen them at that point in time when they come into hospital. Community is much different. It's much more loose, if you will, with respect to primary care. So know a variety of things across a variety of methods can lead to improved nutritional status of older adults living in the community. So CMTF for the last decade has been doing a variety of work, most in the hospital sector, where we first identify the challenges in the acute care sector in terms of nutrition care, the gaps in that nutrition care, especially when people are being discharged back to the community. We then created a pathway of care called the Integrated Nutrition Pathway for Acute Care that is basically an evidence-based, consensus-based algorithm that should fix this issue. We then demonstrated in two studies, the More to Eat Phase 1 and More to Eat Phase 2, that you could actually do this in hospital. It was feasible to put this pathway into place, and it changed what happened to patients and it changed what happened in terms of their outcomes. And that's led now to the development of a national standard around malnutrition that's actually available now on Health Canada and HSO, Health Standards Organization. And it's meant to be a robust standard that can be used throughout the world, actually. So where are we now? We actually thought, okay, well, malnutrition starts in the community. People come into hospital malnourished. They don't become malnourished only in hospital. It's happening in the community. So we went about in 2019 developing pathways of care for people transitioning out of hospital and older adults living in the community because we knew they were highly vulnerable. So this was a long process that started in 2019 with an evidence review, drafting pathways, our primary care working group within CMTF developing this pathway, doing stakeholder engagement, and then a provider online survey that talked about acceptability and feasibility of the practices. And that's the data that I'm going to just briefly show you now that we led to finalizing the models. So this was a survey, online survey that was done in 2019 or so, just before the pandemic. And you can see the people that were participating in this study, many of them were hospital-based because much of healthcare in Canada, dietitians especially, are not in the primary care sector, they're in acute care sector. But what you have on the right-hand side is the agreement with, and I just showed here the transition care practices. But you can see that these practices were identified to be highly feasible and people thought they should be in place in the primary care sector to address nutrition. What I'm going to show you here now, though, is the pathway for acute care for older adults living in primary care and how we should be addressing malnutrition. So you can see, for example, if I got this working right, hopefully. No, I don't. But on the left-hand side, my right-hand side, your left-hand side, people that are at lower nutrition risk, they should be identified by their medical home and provided resources in the community to help them stay in that state or improve their state if they're low nutrition risk. Moderate risk, similarly, involving the investigation with primary care providers to identify why people might be having risk, institute a basic care nutrition plan and monitor them, and put resources and community services into place to mitigate that risk. And then finally, the high risk group, if you have dietitians in your primary care services, to be linking the individuals to that primary care service where you can do a nutrition assessment, develop individualized treatment, and reassess the nutrition status of these individuals. This pathway had 80% consensus for all these key steps that were finalized in the pathway. In addition to the pathway, we asked people, why is this not happening? And these barriers are not unique to prior work we've seen as well in the community sector. People don't know how to connect the dots. If you're working in acute care, you don't know what's going on in primary care. And I don't think this is unique to Canada. I'm pretty sure it's consistent around the world. When you're in one sector, you just don't know what the other sector is doing. They're not sure how people are eligible or not for the various services. And in Canada, we live in a provincial system of healthcare. Every province is different. And quite frankly, every region is different. I live in a place called Waterloo. My mother lives in a place called Clinton, rural community. Very different services are available, which means the capacity to meet the needs of individuals in the community are going to be varied. Inability to access these for many older adults. Much of primary care services are cost prohibitive for older adults, and services don't meet the needs and preferences of many individuals, especially those that are culturally minorities in Canada. What could facilitate this would be having better ways of linking up people to the actual services, so having keep up-to-date data lists and websites around how these services work and how people can get into them, making sure these are covered. In Canada, primary care service, certainly from medical home, having a doctor's care, nurse practitioner's care is covered. My province, again, we have something called family health teams that covers about 40% of the population. All of those have a dietitian. But right now, the mandate is for comorbidities in the middle ages to prevent diabetes and obesity. It's not targeting older adults at all, unfortunately, despite this issue of malnutrition. Other provinces don't have primary care service like that, where they have a dietitian automatically part of the primary care. So there's lots of things we need to be doing and lots of barriers to why we're not doing it. So CMTF has tried to bridge this gap by trying to educate the providers that are there, the nurse practitioners, social workers, OTs, PTs, physicians, about what can be done and what they can do as providers to meet the nutrition needs of older adults, including this basic nutrition care plan. You don't have to be a dietitian to implement these better practices. So what are some of these better practices? So screening and identifying risk. Unlike hospital, where people come in the door and standardized procedures are pretty readily put into place, primary care is not seeing the need for nutrition risk screening yet, and we need to move ahead in that area. Much of the Canada now sees the value, and North America and Europe as well, sees the value of nutrition screening in hospital, right? But they're not doing it in the community sector. Use a valid tool, and the mini nutritional assessment and screen are the two valid and reliable tools that are meant for the older adult population specifically. Assess and use evidence-based treatment that's appropriate to the level of risk to meet the needs of these individuals, including a multidisciplinary team. If you have a dietitian, high risk, but if you don't have a dietitian, doesn't mean you can't do something. And again, the basic nutrition care plan that we've created supports that. Lots of interventions have been evidence-based in the community. We need to basically connect the dots, and that's the problem. We know how to fix this. So I'm just going to show you actually very quickly. This is a key resource that if you're interested in community, older adults and primary care, that has a variety of resources around nutrition screening and how to meet needs of older adults. But I want to introduce you to the screen tool that you probably haven't heard of. If you've heard of any nutrition screening tool for older adults, probably the MNA. But screen is that, again, think about that diagram I showed you at the very beginning. It's upstream. Grocery shopping difficulties, appetite challenges, eating alone. And those are the things that we need to be early on identifying, as well as looking at fruit and vegetable intake, milk product intake, milk alternatives, fluid, etc., and some other key risk factors, obviously. So one of the issues about screening is the World Health Organization has put into place screening principles now almost 50 years old, that if you're trying to put any screening program into place, regardless of its setting, you need to meet these principles. And we know that we do. We just need the action to do it. Malnutrition is an important health problem for sure. There's accepted treatment for malnutrition. There are processes and facilities to diagnose and treat. Nutrition risk is a recognizable early stage for malnutrition, and there are suitable screening tests available. Screening tools are acceptable to older adults in the community. We've been using MNA and certainly Screen for many years now. Natural history of risk of malnutrition. Malnutrition is relatively understood. We know that if we can stop nutrition risk, we can prevent the malnutrition happening. Case finding with screening will identify who to treat, and cost of screening likely outweighs the benefit, but we don't have a lot of evidence around that itself. And we do, though, have pathways to provide for continued process. So you're probably wondering why I'm up here, because we're not doing it, right? We have everything we need to do, but we're not doing it. So my takeaway messages for you today are nutrition risk is definitely prevalent and needs to be identified and treated before malnutrition develops. And the greater burden is older adults. With our World Health Organization Healthy Aging Initiative and the ending of the Action Nutrition Decade, it's about time we stepped up. We've got valid tools, we've got effective treatments, we have evidence-based pathways that are available that can be adapted to diverse healthcare systems. What we need to do is policy. We need to have healthcare professionals prioritizing nutrition risk and not seeing it as something that is not even recognizable as an issue. And we need to minimize the burden on gatekeepers so we actually achieve this outcome. So with that, I thank you very much and acknowledge Canadian Malnutrition Task Force, CNS, my working groups there. Thanks very much.
Thanks very much, Heather. This is a really important area. Can I push you a little bit? Because you focused on the importance of screening and you have your care pathway, which, you know, is wonderful. But the key issue is getting older people to eat more. And you have problems like, you know, anorexia of aging, dysphagia, you know, lack of being able to get around, poverty, all of those things.
Yep.
So in terms of your care pathway, I mean, I know you touched on implementation, but are there some sort of novel ways to actually implement? Because of course, when you screen, you find things,
Yep.
and then you're expected to do something about it as clinicians.
Absolutely.
So,
yeah, and I think the key is older adults, and all of us now recognize the importance of nutrition, right? I think the key is with older adults linking it back to the frailty and function issue, right? No one wants to be debilitated. No one wants to be in a wheelchair. No one wants not to be able to get up down the stairs or play with their grandchildren. So linking nutrition to frailty is a key issue. And so in Canada right now, we're doing it in falls clinics, immunization clinics, etc. Places like that where older adults come because they don't want to be unwell. And then they realize, oh, nutrition is a part of this too. So you're right, we absolutely, Philip, have to educate older adults on the importance of nutrition. I think in general, they see the importance of nutrition for things like obesity, but they don't get how nutrition impacts my function. So that education has to happen for the older adult themselves as well, and to prioritize that.